Good evening, everybody. My name's Dan Fagan. I'm a professor of journalism here at the Carter Institute of Journalism at NYU, and I'm the director of the Science, Health, and Environmental Reporting program. We're so glad that you're with us, both here in person and online, for a discussion about journalism and long COVID. It's a topic that we all wish we didn't have to address, but we really need to address. So I'm very happy to have two wonderful guests here that Monica and Betsy, that Robin Lloyd will formally introduce. But I'll just say thanks to both of you for coming. We really appreciate it. And as always, we're very grateful to Robin Lloyd, who is a visiting scholar here at the Carter Institute and a longtime science journalist and faculty member here at CHIRP, who organized this session and will moderate it. Robin does a fantastic job, and we're very grateful to her. We do have another, our next Cowboy Conversation on Science Communication will be on the 27th, when we will be featuring Elizabeth Colbert, who will talk about her new book of essays. That'll be great. And the person who illustrated the book will also be here too, and we're very thrilled to have them both. So in any case, Robin, take it away.
Thanks. It's great to be here, and I'm really excited to talk about this subject, really important topic. So I'm just going to launch into it because we have a lot of definitions actually to sort of set things up. So let me introduce our wonderful speakers tonight. We are so lucky here to have both of these experts in their field. Dr. Monica Verduzco-Gutierrez is an academic physiatrist. This is a physician who works on restoring function for people who've been disabled as a result of a chronic condition, a disease, disorder, injury. She is also professor and chair of the Department of Rehabilitation Medicine at the Long School of Medicine at University of Texas Health, San Antonio. She previously was a medical director of the Brain Injury and Stroke Program at a top 3 U.S. News and World Report Best Hospital for Rehabilitation. Dr. Gutierrez grew up in South Texas and then moved to Houston, where she earned her undergraduate degree at Rice University. I think I should cut this short. Yeah. Most recently, she helped develop post-COVID recovery clinics to help those who are diagnosed with COVID-19 and suffer from various physical, cognitive, and functional difficulties. And we are also very honored and happy tonight to have Betsy Ladyzhets here. She's an independent science, health, and data journalist and writer focused on COVID-19 and the future of public health. She is the co-founder of The Sick Times, which is a long COVID news website. It's wonderful. I really recommend checking that out. She also ran the COVID-19 Data Dispatch prior to The Sick Times, which is a newsletter and blog that provided news resources and original reporting on COVID-19 data, and that outlasted the CDC's own COVID-19 data newsletter. She was also, she does investigative work, some of it with Muck Rock, and has some other plaudits too that I will leave out right now. So, Dr. Monica Verduzco-Gutierrez, could you tell us a little bit about your work in the field of rehabilitative medicine and physiatry, and then how that kind of had a natural fit with taking care of long COVID, and your practice seems to evolve, your specialization, your research has evolved in that direction, is that right?
Yes. So again, thanks for having me here today. You've been just wonderful so far. The weather has not been so wonderful so far, but I will deal with it with an umbrella. I prepared. So my field is physical medicine and rehabilitation. I'm a physiatrist, and this is a field that's very diverse because some people take care of like sports injuries, and I went into it, and I have a subspecialization in brain injury medicine. So I took care of patients who had strokes, traumatic brain injuries, several concussions, other major neurologic conditions. And these patients usually have tons and tons of issues going on. They have headaches, they have migraines, they have mood disorders, they have motor disorders, they have heart issues, and so many different things. So I would have to really take care of a patient holistically that way. And then came COVID-19, and COVID-19 also shut down a lot of medicine, shut down a lot of outpatient practice that I couldn't take care of there. And so part of me said, how am I going to be relevant during this time? And then also saw the need of knowing, like, gosh, there's so many people, they're hospitalized, they're being really impacted. We know that persons of color are more impacted by this virus and disease. So I said, we have to do something to step up and make sure that they get rehabilitation and taken care of. And so it kind of pivoted to long COVID, or to post-COVID, I guess. And then a lot of post-COVID's just become long COVID, which we'll talk a little bit more about. And these patients are very much like my patients who have brain injuries. And that's where it was very easy to be able to say, okay, well, I know how to deal with someone who has dizziness, and someone who's developed migraines, and someone who has pains and joint pains and numbness and tingling, and all the other myriad of symptoms, fatigue, because sometimes my MS patients have a lot of fatigue. And so use those skill sets to become a brain injury physiatrist for long COVID now, and have used that to now have a large $5 million AHRQ grant to kind of increase our work, and have probably close to publish like 50 papers around long COVID, including a lot of clinical guidance statements for other specialists to read about.
What's AHRQ?
Oh,
It's some NIH thing.
It's some NIH thing. Yes, it's some NIH
Association
thing.
for Healthcare Research and Quality, I think.
That sounds
I
right.
wrote a story about these grants, so I should know. But yeah, I think that's what it is.
Well,
Yeah.
this is a good segue then. Betsy,
Yeah.
tell us how, you graduated from college, and, like a year later, bam, the pandemic hits. Tell us
Yes.
how, from college to the sick times, this transition occurred for you.
Yeah, so when the pandemic started, I was working at a news site called Stacker, which does data journalism, and I was their staff science reporter, basically. I was leading their relatively small science and health vertical, mostly because I was the only person on staff with a bit of a science background, having majored in biology in college, and I thought it would be a good thing for us to do. Which came in handy when the pandemic started, and then suddenly I was in charge of a lot of the COVID coverage, finding data for stories and that sort of thing. I also, early in the pandemic, volunteered for the COVID tracking project, which, for those who don't know, is a big volunteer effort to basically keep track of COVID cases, deaths, testing, and other really common metrics at a time when the CDC and other federal health agencies were not doing a great job of making that data available and easily accessible to people. So that's what I and many, many other volunteers were working on. And after a few months of this, I wanted basically a space to share what I had been learning, share my own thoughts and opinions on COVID data with other reporters and with my friends and family. So I started the COVID Data Dispatch newsletter. Initially like a pretty small Substack project, but it grew over time to include more original reporting, things like interviews with people who are working on complicated COVID data questions. And then eventually I was doing too much, so I left my staff job and started freelancing, continued to do a lot of reporting on COVID data, tracking things like breakthrough cases, eventually wastewater surveillance. That's a big topic that I've written about a lot. And long COVID kind of came into the picture too, as I was really interested in like how we were tracking this, how we were trying to understand it, and also the experiences of people with long COVID. And so this past year, after freelancing and writing this data newsletter for a while, I started to see kind of a change in the media landscape around COVID. Many of the data sources that I had relied on were shutting down or becoming less reliable, and so that was kind of a less interesting area to be writing on regularly. And sort of in contrary, long COVID just seemed to be more and more of a topic that needed more reporting. Particularly, I was having experiences that I know other journalists on this beat have had of trying to pitch stories to different outlets and getting rejected or having the story cut down, pitching something that I thought would be a major investigation and having it shortened to a small news story that I felt didn't really capture all the nuances or fully explain the situation. And so that was kind of frustrating. At the same time, I was having these experiences, I was seeing kind of poor long COVID coverage in major media outlets, features that got big things wrong about this disease or even led to calls for retractions by the patient community. And so that was where I had the idea that maybe we needed our own outlet, as people researching and reporting on long COVID. And to start that, I teamed up with a friend of mine who had been involved in some of those efforts calling for retractions and commentary, and who is also a freelance journalist. So that's my friend and co-founder Miles Griffiths. And so, we've been working on the sick times for a few months now. We started the brainstorming process last summer and then formally launched in November. And so it's been a few months of reporting stories, fundraising, setting up our website and newsletter and social media and all the other stuff that comes with starting a new publication. Yeah.
Oh my. Well, I definitely want to get into the misunderstandings and the retractions, but first let's just define long COVID, because
Yes.
it's a relatively new condition and it's not that easy to define, I suspect. So, Dr. Gutierrez, obviously, I would like you to talk about that.
Right, such a point of contention. So long COVID, there's different definitions, CDC, World Health Organization, and then I'm going to give you the Monica definition. Okay, so the way I feel is long COVID is, a disease state that people have after they've had COVID-19, and sometimes that is going to be, we don't always have to have a positive test, because sometimes patients don't have access to testing and such, so, presumed or definite SARS-CoV-2. And then they have a set of either symptoms or conditions that develop afterwards. And it doesn't always have to be, so it can be symptoms that can occur from all types of body organ systems, so it isn't just one thing. And then conditions are, regular kind of diseases that can happen. And then the other thing is sometimes also that someone has an underlying condition that they had, and COVID just makes that worse. So it's either, you're developing something new, you're exacerbating what you already have, or some continuation of symptoms maybe that you had when you had COVID. And then the other thing about it is that you can have COVID, be completely well, and then something just totally new symptoms come on within a certain time period, and that these symptoms continue to go on, but they can wax and wane, which means like relapse and remit. So someone might be feeling great and they then may not be feeling great. So it's very broad definition, but I think it needs to be really inclusive of all the people that are suffering with long COVID.
Yeah, when I was looking on the Centers for Disease Control website, just to get their basic background on long COVID, I noticed there was 7 different alternative phrases for long COVID that are out there. Do you think that this is just a result of this being such a new condition, just that we're so early on in understanding and managing long COVID, or is there more to it? Is this what we would see with about any new condition?
So I think that long COVID is new because because SARS-CoV-2 just started, 4 years ago, but infection-associated chronic conditions have been around for a long time, since, before the flu of 1918. People can have long flu, they have post-polio syndrome, and, polio is something that's happened decades and decades ago. Patients get ME, myalgic encephalomyelitis, from infections as well. And so these have always been around, but just not in quite the numbers that we're seeing. And so I think that's maybe it's brought more attention to these infection-associated chronic conditions that have been definitely underfunded and not, gotten a lot of attention before. And so I think that's what makes it different, new. Did I answer your question?
Yeah, absolutely.
Okay,
Thanks.
all right.
Yep. Betsy?
I think a bit of the different names too is different approaches of thinking about this disease coming from different directions. Like long COVID, for example, is a name coined by patients. And so that name sort of refers to the patient experience, right, of long-term symptoms. But there's also the more clinical definition, PASC, or like post-COVID. You know, those kinds of terms are more for the doctor's side of like seeing things happen after a acute COVID infection. And I think part of the challenge too with researching it is that many of the scientists or doctors who are looking at long COVID might come into it from their existing area of research. Like somebody who is like a respiratory specialist and they see people, you know, coughing for a long time, is going to have sort of a different view than someone like Dr. Gutierrez with her background. So I think that's part of the challenge, is it impacts so many different organ systems. And I think medicine and medical research often is used to looking at one organ system or one symptom at a time. And you can't really do that with long COVID because it's, for a lot of people, it's sort of everything at once or many diverse symptoms at once. And I think that makes it hard to define and hard to study.
Yeah, Dr. Gutierrez, you talked a little bit about the prevalence. Can we talk a little bit about that? I mean, the numbers, I was stunned, really.
Right, so kind of the best place right now where I'm getting numbers is a household pulse survey. So they started asking Americans.
They just updated it.
They did,
Yeah,
right.
yeah.
And so it was, one thing was like a percentage of Americans who've ever had long COVID is about 17.2%, I think. And then people who are currently living with long COVID, it's about 6.3%, if I'm remembering
Of the U.S. population.
of the U.S.
Yeah, okay.
population.
Yeah.
So
Yeah, it's been around 5 or 6%, I think. They do this survey every couple of months. And so the most recent data that was just updated is, I think, as of January 2024.
Mhm.
Yeah.
Yeah,
You
so
can fact check me
more
on
than
that.
10 million,
Yeah.
people are currently positive.
Right.
Yeah.
Yeah, if you think like even maybe 1 in, 17, 18 people are living with long
Right.
COVID.
Right, yeah, I saw that
Right
somewhere
now.
too. It's
Yeah.
astounding, yeah, the prevalence is quite significant. So what are some of the fundamental misunderstandings that people have, like the prevalence of long COVID that you come across? What are like the top 2 if you had to, I mean, there's so many, I suppose. I see Betsy shaking her head.
There's a few. I mean, one that we're like really careful to avoid at the Sick Times because we find it very frustrating when we see it, is saying that long COVID is symptoms that can last for weeks or months. Many people have been sick for 4 years at this point. So saying weeks or months can be considered a bit, not fully capturing the scope of the problem. Another common challenge is with stories of people who have long COVID. These narratives often focus on people who were young, healthy, often people who have great access to health care. And I think there are a lot of biases that go into not who has long COVID, but who is able to identify that what they have is long COVID, right? If you think about both access to media, access to particularly like specialized popular science media that is covering this disease, a lot of people don't know about long COVID, even though they might be dealing with some kind of symptom. And so I think there's a challenge there in, who is able to identify this, who is able to go to a doctor and ask a lot of questions, maybe go to multiple doctors because the first doctor doesn't believe them, that there's something wrong. Maybe go to a specialist, get testing done, and all of this stuff takes time and resources that many folks don't have. And so that also impacts, I think, who shows up in our media coverage. And so I think that leads to kind of a bias in who we see presented as like a long COVID patient. And how those narratives kind of shake out. Also, a lot of people with long COVID, as Dr. Gutierrez mentioned, had some other kind of chronic condition or disease that then is worsened by a COVID infection. There are a lot of people who had, say, ME, and then they get COVID, and then they have like a relapse of those myriad symptoms. So I think it's important to include those people in our coverage too. And that's something that often doesn't happen when you have sort of the standard media narrative or essay of like, oh, I was completely fine, and then suddenly, bam. Like those narratives are important, but there are also a lot of other narratives.
All right, my thought, maybe from a physician perspective even, is that there's even some physicians that don't know what long COVID is or
Yeah.
what it means or how to see or address a patient. I've known physicians that have kind of like had long COVID and didn't realize that they were living with long COVID until we kind of discussed through some of their symptoms. And so it's also, you know, if you're going to be interviewing people, also make sure that they understand their science and what's going on. What else was the thing? The other thing is the patients that we see. So if we look at the data that I always say, who has long COVID, it's a bell curve, and it happens to be, you know, in this data that we sent, a lot of people who are 40, in their 30s, 40s, but it can be across the age spectrum, so kids and all the way to older adults. And again, it's going to impact people different ways. And currently, it says, you know, women are impacted more than men, and so don't let that, again, bias you, because maybe men aren't going to get health care. A lot of times men don't want to go get health care. So are we undercounting, you know, men who may also be dealing with symptoms and haven't gone to get help for it? And again, just also, the other thing you'll see that this is happening a lot in minoritized and racialized groups, and so it's important to hear their voices, because often those voices aren't heard.
Yeah, one of the things that I had to learn myself getting ready for this event is to not think of long COVID as a mysterious disease. That's a moniker that patients and probably clinicians as well are not really pleased with, and the reason for that is, can you say a little bit about that, either one of you?
Oh, so I will also say that physicians get crap education on like infection-associated chronic conditions, like for dysautonomia, POTS, ME/CFS. That's maybe I don't even think we had a lecture on that. I think it's maybe something we read. It's something that, yeah, maybe we got it in residency, because my specialty deals with autonomic dysfunction, but there isn't usually, just like we get lectures on infectious diseases and what happens in the acute side of infectious diseases, we don't really learn very much what happens in the aftermath of them. So that's something also that is unfortunate.
Right, POTS is this postural orthostatic tachycardia. Your heart races when you stand up uncontrollably, is that right? And that's an associated symptom? Right, so POTS, or postural orthostatic tachycardic syndrome. So this is part of an autonomic dysfunction, and you know, there's different types of underneath autonomic dysfunction. POTS is probably the most common one, and you're right. When someone gets up, so when they're in the upright orthostatic, you know, posture, their heart rate goes up, and it goes up by 30, 40 beats a minute when they're up, and that's because their vessels, their vasculature isn't responding the right way, and they're not getting where they need blood to get to, which is their brain, and so that's why they have all the symptoms: dizziness, shortness of breath, brain fog, ringing in their ears, pain in their neck, because basically you're not perfusing your brain like you should be.
Yeah, so I think that ME, and there are a bunch of other, you know, post-infectious chronic diseases that are not new. You know, there's a lot of research on them, a lot of people who have them, patient advocacy work dating back decades, but they were not really in the limelight much before the appearance of COVID and long COVID. So I think that's one reason why some journalists or some scientists might think of this as mysterious when it's not. Really, we know a lot, particularly if we take the lessons from all of this past research. Also, even just with long COVID, there have been thousands and thousands of papers in the last 4 years. I say that as a journalist trying to keep up with the research. It's very challenging. There are like new studies every day. And it's hard to even decide what to put in our weekly newsletter at the Sick Times, because there will be maybe 10 studies that we think are interesting, and we try to pick maybe 3 or 4. So there's really a lot of work going on to understand this disease and to understand all the myriad symptoms and the biology of what might be happening in people's bodies and all of that stuff. So there are obviously many unanswered questions, but also a lot that we have learned and a lot that we can say. And so that moniker of mysterious is, maybe it was accurate in spring 2020, but it's not now.
Gotcha. Can we talk a little bit about treatment, Dr. Gutierrez? So, you know, what are I mean, there's so many systems that are affected, and there's not been a lot of research. In fact, I read on one website there are 0 proven treatments for long COVID, but maybe we're just treating the condition, the symptoms. What's available? What is being looked at so far?
Right. So definitely, there's nothing that You know, FDA has not approved any treatments for long COVID, so that's something that's, you know, unfortunate because we really got very quick during COVID, you know, treatments to treat people when they were acutely ill, but now that they're chronically ill, it's kind of gone by the wayside to do, you know, treatments for them. So yes, as far as, you know, I just have to use my skills to say, all right, what are the different kind of, what is the syndromic part of long COVID that you have, and what are the symptoms or what are the conditions that you've developed? And I can, what's sad is a lot of patients are told like, oh, long COVID, we don't have a treatment, you can go. But if someone shows up and they have POTS, we have medications that, you know, both non-pharmacologic things to do and pharmacologic things to do to control people's symptoms with POTS. I may not be able to like take it all away, but I can control your symptoms better. If someone has migraines, there's lots of treatments for migraines. If someone has, you know, dizziness, there's vestibular therapy. If someone has fatigue, we have to see what type of fatigue it is. And if it's, you know, post-exertional malaise, which is, you know, they do something and they crash with any little activity, or is it just kind of a little bit more fatigue, but they can still do activity, and educate people those different ways.
Yeah. And there is going to be, or underway, is a clinical trial with Paxlovid. Is that something you've written a little bit about or looked into a little?
Yeah, there are a
Betsy?
couple of clinical trials with Paxlovid. So one is part of the RECOVER study, which is a big initiative by the National Institutes of Health. There was also a Paxlovid trial at Stanford. That one actually ended early, a little bit unclear why, but one of the reasons may be that they didn't have significant results. But
Paxlovid is it's the major antiviral.
Yeah.
There's a couple of them. That's the major one.
yeah, and I guess to give a bit of context as well. So one of the main hypotheses for how people might get long COVID or long-term symptoms is an idea called viral persistence, which is essentially the hypothesis that the coronavirus continues to live in different parts of the body and continues replicating and continues to basically disrupt different organ systems. And there are a lot of studies that have shown the coronavirus or pieces of it, like the spike protein, persisting in different parts of the body for a long time. And so one of the common hypotheses for how to treat long COVID, following from this research, is the idea that you get an antiviral, and the antiviral would help to treat this persistent virus. So that's why a few studies have looked at Paxlovid for long COVID in addition to acute COVID. There are also a couple of papers that suggest that maybe getting Paxlovid in your acute phase, like the first week that you're sick, could reduce chances for long COVID, although other studies have shown that it doesn't do that. So the science, I think, is a little unclear. And probably more clinical trials like the one that's happening through RECOVER will give a bit of a clearer answer on that.
And my 2 cents is, if I was a betting woman, I don't think it's going to pan out. I don't know. It just depends.
No, I mean, it's unclear, I think, but I think there are other like novel antivirals also that people are interested in, and sort of an effort to maybe develop new drugs too. So.
But I'm just
Yeah.
excited that they're doing clinical trials on, antivirals and such.
Oh, yeah.
And now we need to really look at the immune system, because part of long COVID is a dysregulated immune system. But it's interesting because some people's immune systems doing too much and some people's immune systems doing too little. And if you give someone whose immune system's doing too much the thing to help shut it down, that's not going to be good for someone who's on the other spectrum. So
It might be the treatments have to be real,
very individualized.
Yeah.
Yeah, I mean, I hear some researchers compare long COVID almost to cancer and saying like, we have one term for what is actually a very diverse disease. And so in the future, I think there's going to be more of an effort to, still use this umbrella term, I think, but maybe better understand like subtypes or what treatment might work for what person.
I also heard something really great. It was like a boat that has an anchor, but it isn't one anchor, it's 3 anchors that's anchoring the person down. So one anchor is like, okay, well, we found they had microclots. That's one of the hypotheses, and hyperactivated platelets. And maybe we figure out how to treat the microclots, But then there's still two anchors anchoring them down once you do that, which might be dysregulated immune system, which might be gut dysbiosis, which
Yeah.
might be, you know, endothelial dysfunction, for example.
Like allergies from mast cell activation syndrome or something, whatever.
Can we talk a little bit about the healthcare system and healthcare workers? Obviously, just occurred to me, there's going to be a higher incidence probably of long COVID. Is that true in the healthcare community? And then you have personal experience as well, Dr. Gutierrez, with long COVID. Can you talk a little bit about how it's affected your field?
Right. So I see a lot of frontline healthcare workers. So whether that be, you know, nurses, doctors who are there in the front lines that are dealing with long COVID, police officers, firefighters as well. I know they've done studies to look at healthcare workers before. I don't remember all the data, but it's pretty surprisingly high number of healthcare workers that have dealt with long COVID. And then myself also have had or have lived experience with long COVID, just I'm able to have it much better controlled than it was. But it was very ironic to be, you know, vaccinated, healthy, have the mildest of COVID when I had it. Like literally it was just felt like allergies, got over it really quickly. It was just more of annoyance, especially because I was on vacation when it happened. And then like 2 weeks later, just went on an easy jog and bam, was like hit and broke out in hives everywhere. So talk about mast cell activation, got a migraine that lasted like 3 weeks and was like just down. Everything just caused like major PEM.
Had you already been treating patients with COVID or long COVID at that time?
Yes, I did. So it was already, I knew what was like happening. I actually got myself enrolled in the RECOVER trial as a RECOVER participant because I was like, I needed to know, you know, I want to see what's going on, or maybe this will get me access eventually
They do
to
a lot
trials.
of testing, so I know that's one advantage for some people.
They do a lot
Yeah.
they do a lot of testing, yes. I don't even know if I've ever seen my results of those actually, but oh no, I did. I was like, oh, I get pulmonary function tests. I have asthma and the lungs of a 59-year-old. Which was on there, and I was like, I'm a like mid-40s marathon runner. My last marathon was in New York in 2019, like, you know, and now I can't barely run 3 miles. So, and it's also hard when you go to your doctor and you say, I can only run 3 miles, but that sounds great. But she doesn't understand. I used to run, you know, through all the boroughs here.
Dan, did you want to?
Yeah, I thought I would get the questions rolling here. So when I heard you talk about those incidence numbers, that was really staggering. And I immediately thought, wow, long COVID really needs to be a higher priority at NIH. We have to get more serious about this. But I often feel that way when I hear about, you know, any condition that seems. Well, I guess what I'm saying is, as a journalist, I always have a really hard time figuring out, is something undercovered and is something underfunded? Because I'm not really in a position to sort of make, you know, come up with sort of a broader context in which to make good judgments about, does something deserve more coverage, does something deserve more funding? So I guess for each of you, both from a clinical standpoint and also from a journalist standpoint, you know, as folks that specialize in this particular condition that is so, you know, pervasive, how should we be making those judgments about what deserves attention and what deserves funding when we're not really in a good position to make those calls?
Yeah, it's a tough one. Go ahead, if
definitely-
you have thoughts.
My thoughts are, it's definitely underfunded for sure. I know that when you look at even, okay, we have RECOVER, and RECOVER has its limitations, and it was only $1 billion, $2 billion?
I don't think people know about
Oh, yeah,
RECOVER,
go ahead.
so.
Oh yeah, should we give, sorry. So RECOVER, for those not familiar, is a kind of poorly named, in my opinion, study from the National Institutes of Health. They received about $2 billion from Congress at the end of 2020, with a mandate to study long COVID and provide treatments. So it's been a couple of years, and they set up, this giant study. They got a bunch of different institutions involved. NYU is actually one institution that has a major stake in this. It's in charge of the observational study, and coordinating sites across the country that have recruited patients, are doing a lot of testing and basically trying to understand what's going on. And it's been heavily criticized. I've reported on it a lot, and have heard both from people in the patient advocacy community and other researchers who are not part of the study, that they feel the money maybe didn't go in the best directions. Particularly, I think a couple of the criticisms are the major focus on this observational research, when, as I said earlier, there have been many, many other studies on long COVID from this observational perspective already. And so there's a question about sort of what Recover adds to that. It's kind of a tough question to answer because they're just starting to publish their results now from that study. But then another big criticism is that, part of the mandate from Congress initially with this funding was to research treatments. And first, it took them a very long time in the grand scheme of the pandemic and the number of people suffering. It took them a couple of years to start the clinical trials that happened this past summer. And there's been some criticism around the clinical trials, which I reported on, that they're maybe not looking at the most promising treatments, like we were just talking about Paxlovid. That's one of the trials. Another one, to give an example, is sort of a computer like brain training program. So just not the potential treatments that a lot of people in the patient community and in other areas of research are most excited about, or that people think could most benefit from the scale of government funding and organization provided by Recover. So I think that's the basic rundown. They did recently announce the NIH has provided an additional $500 million to Recover, so kind of 1.5xing the budget there. I'm hoping to do some more reporting on it, so if anyone who's watching this and has thoughts, please email me.
But if you look at, how much money is given to anything else, how much money they put into National Cancer Institute and those types of things, this, even $1 billion is nothing, especially for something that has impacted 17% of the population of U.S. adults.
Yeah, I mean, there are advocacy asks. One is $1 billion a year for at least 10 years. There's another group asking for more on the lines of $40 billion a year, which is the number they got from research into the economic costs of long COVID. So definitely a lot of people think there needs to be more research funding.
Okay, thanks.
Hi, my name is Avery. I'm a student with the Science, Health, and Environmental Reporting program. I'm also a former healthcare worker. I worked with a lot of COVID patients and post-COVID patients, and I think one of the patterns I always noticed was this kind of shadow of doubt that overlies, I wouldn't want to say everything related to COVID, but certainly post-COVID. And I'm curious, both from a medical perspective and from a reporting perspective, how you would approach kind of either reporting on or discussing these topics that not most, but maybe a lot of people don't necessarily believe to be true.
Yeah, there's tons of COVID denialism. It's prevalent, it's widespread in the United States, and of course post-COVID and long COVID denialism. How do we address that?
And it's become really political as well.
Oh my gosh, yeah.
Yeah, it's not the policy school, so we won't go into that. But do I have a good answer for this? I think just when you are going into, if you being open to it, you being willing to talk about it is a big step for someone who you're interviewing, that you believe them, that that you're educated about the topic, so you come with education, and then I think that will, whoever you're interviewing or talking to, will empower them to want to speak about it and continue to do your good work.
Yeah, I think part of this goes back to terminology as well, because often if you ask someone, do you have long COVID, they're probably going to say no because they don't know what that is. But if you reframe the question and say, after you had COVID, did you feel anything out of the ordinary or any existing conditions that you felt were worse, or weird symptoms that you kind of didn't recognize. And I think more people might be likely to say yes to that question. And we actually see evidence of this in the household pulse survey that you cited earlier, with those data points, because the way that survey is framed, they ask the question the second way, right? Where they don't say, do you have long COVID, but they ask, have you had symptoms? I forget the exact time period that they use, but maybe a month after or 3 months after a COVID case, right? And so part of why the estimates from that survey, I think a lot of people in the advocacy and research communities find to be maybe more accurate, is because they're not restricting it by the terminology. And I think talking about it in that way is also important, because, long COVID is not restricted to like liberals or people who have science backgrounds. Anyone can get it, but being able to recognize it, I think, is maybe tough depending on where you are, what kind of media you're reading, and other things of that, like what kind of healthcare access you have and all of this stuff. I think being able to talk about it in a way that is free from jargon or free from medical terminology, I think is important. And this also goes into, the need for more outreach and education, which I'm trying to do with the Sick Times. I know your clinic does some of this too, but I think all of that is really important.
Yeah, thanks. Priyanka?
Hi, I'm Priyanka. I'm a science and health journalist and a former COVID reporter. I am wondering what recovery for people with long COVID looks like. Essentially at the long COVID clinics, are we tracking this process of recovery if it is ongoing? And Betsy, how are we covering this recovery process?
It's complicated. I think different people have different kinds of experiences with it. Some folks are able to get to what people call like a baseline, or an ability to sort of perform day-to-day tasks that's maybe lower than what it was before getting sick, but still something that's manageable, maybe for like working part-time or something along those lines. For other people, symptoms can fluctuate. For some people, symptoms get worse over time. Some people I've spoken with are bound to their rooms or their beds, and they really can do very little because of long COVID. And I think those are all kind of different possibilities. Another thing that I think is challenging in the scope of long COVID recovery is reinfections. My colleague Miles, who's my co-editor at the Sick Times, had a great piece about this a couple of weeks ago, which he wrote because of his own experience with a reinfection. And I think for a lot of people, as he found in reporting that story, if you have long COVID and then you're infected with SARS-CoV-2 again, you can have new symptoms, you can have worse symptoms. And in the piece, he describes it as almost like Sisyphus pushing the boulder up the hill, right? Where like you're making some progress, and then you get reinfected again, and you're sort of pushed back down. And it can be really, really hard to deal with that, particularly in our current, situation in the United States and in many other countries, where it's really hard to ask people to mask, even in medical settings, even in long COVID clinics. In some of them, it's not required to mask. We haven't made a lot of great progress on air quality, air ventilation in indoor spaces. Testing is less and less available. And so with all of these tools kind of becoming harder to use or less popular or more politicized, reinfection is unfortunately very likely in many spaces. And so I think that really makes things hard for a lot of people looking to recover.
And I'm coming from Texas, so there you can't even like mandate masks, even in hospital settings. So it's kind of the letter rip in down south. But okay, now I'm like, what was the question? There's some long COVID shining through. Oh yeah, recovery. Okay. So with recovery, there are some patients, if you look at, big number data sets that studies, there are a subset of patients who feel that they get better. I do have some patients that they don't need to come back. Well, first, some don't come back, and you're like, is it they don't come back because they're better, or do they not come back because they're worse and they lost their job and they lost their access to health care and insurance? And maybe care to getting into clinic, a caregiver to bring them in, or an ability to even do the telemedicine visit. So, but there is some studies that show, a percentage of people do get better, but then, as it was said before, it just really depends. Some have declined significantly. Some are, have to live in their home and be kind of bound to their home or their room. Some can, I like to say it's like a simmer, like it's a little fire, but it's a simmer and it's controlled. But anything, including a reinfection, can put, more flame on the fire, and then it's like COVID again, and their long COVID symptoms coming back with a roar.
Thanks. Olivia.
This is a related but I think distinct question. I'm wondering, I'm interested in kind of just accessibility for people who have like long-term invisible disabilities, and I think it's interesting to think of long COVID as sometimes falling into that category. So I'm wondering if, like, what are kind of the ways that just like normal, or not normal people, just like uninfected people, people who are not really dealing with the long-term diseases of this, can make the world like a little bit more accessible, and like how can we make spaces like this or school or work more accommodating for people with long COVID?
I think a lot of it is what I just mentioned, like being willing to have masks. I appreciate that many of y'all are wearing masks, so thank you. To that note, improving indoor air quality is one thing that also we can do that would make masks less necessary in these kinds of settings. Making testing more available, and really just all of those tools that can help mitigate acute COVID, also mitigate risk of long COVID, risk of reinfection, and all of those things. I think also education and sort of being aware of this, and being able to help educate people is really important too.
I agree with everything said. I think I also look at it from, when I'm an employer and I have faculty or employees that work for me that may be dealing with, other types of invisible illnesses. It's Brain Injury Awareness Month, and a lot of patients with brain injuries also kind of may present like a long COVID patient and also may look like they're just fine, or people think that they look fine because they're able to walk and talk. But also just making sure that the workplace is accommodating for them. So I am there is a ability for sometimes people to, shorten their load. So maybe they're not seeing as many patients if they're a physician, or to be able to do more telemedicine and work from home and be able to be flexible with, those types of accommodations. I'm a physician that very much, I'm very accommodating for patients even with long COVID, like here's a disability hang tag, even though you can walk, but if you were to walk the whole way to work, you use all your energy and then you can't do work, or, and so I kind of take those invisible disabilities into consideration and try to say, how can we help accommodate them as best as possible so that they can, live a life and participate in society as much as possible.
Hello, I'm a audio journalism student here working on a investigative piece about long COVID in children, and I'm curious what you've seen as far as research, as well as medical support, as well as reporting, how much children are included in the conversation about long COVID and how it maybe differs from some of the research and reporting on adults, or kind of widely.
So as far as reporting, maybe I don't know all the studies that, stories have come out from reporting, but I know it's really hard. Children are impacted by long COVID, as you know, and it's even harder to get, there's even fewer pediatric long COVID clinics, much fewer than there are adult long COVID clinics, even though there aren't even that many of those. And so it is really hard for children to get access to that kind of care. And so that is something that, I'm so glad that you're studying it and looking into it, and we'll do a report about it.
Yeah, glad to hear you're working on it. I did an interview recently with a researcher at Columbia University's Medical Center who's involved with the Recover initiative that we were talking about. But specifically, there's a part of that initiative that's focused on children. And so they're doing the same kind of observational research that is happening for adults, but with kids. And this researcher, Dr. Melissa Stockwell, I think is her name, was talking about how they're trying to include children of every age group, from infants up to, I believe it goes up to young adults, so like early 20s, and trying to track patients over time, trying to understand what's happening biologically. One thing that she said to me that really stuck with me is that the mechanism hypotheses that we've talked about, for example, viral persistence, could look different in children. Like if you think about a young child who gets COVID as, say, a 2-year-old, and they have a virus growing in different parts of the body, and then they're growing and now they're a 4-year-old, a 5-year-old, like that might look different biologically speaking than it does for an adult who's already grown at their full size. And so I think these are really open questions that that Recover study is looking at. But you know, talking to Dr. Stockwell, she also really emphasized that, like Dr. Gutierrez was just saying, a lot of pediatricians really don't know what this is. It can be really, really hard to find care. It can be really hard to recognize that something that a kid is going through may be long COVID. That all the same biases of who has access to healthcare, who has access to media that is talking about this, that they would know what it is. Like all of that, I think, is multiplied in children. And I think with kids there are also unique challenges that I know have come up with a couple of researchers I've talked to on this subject, with like school accommodations and, you know, what are the implications for a kid who might be sick and might be missing out on school. So, you know, adults might need work accommodations, children might need school accommodations, and I think that can be really hard in some places, all the pushes to return in person and all of this stuff. So I think both the biology might look different. I think people are still working on that, and then also the needs and the kind of support systems that could be necessary for kids might be different.
Next.
Hi, I'm Janae. I'm a student with the Science, Health, and Environmental Reporting Program. And so we've talked a lot about like defining long COVID as well as the concept of recovery and outreach and getting proper medical care. But I'm really curious if we could talk a little bit more about the actual treatments that could be utilized. Like we're really in the infancy with some of like these long COVID specified treatments, but especially as someone who is dealing with long COVID and has taken certain medications, I'm really curious, you know, like do patients need to be aware that they're going to end up taking a bunch of different things all at once? Like, should they be aware that like maybe they might end up taking something that seems a little bit counterintuitive but could ultimately help them? Like I've started taking like SSRIs, and those have helped me with long COVID, and I did not think that that would be the case. And so I'm really curious, like especially as a physician, but also as a reporter, how do you sort of discuss these topics of like medications for patients or people who might not fully, grasp the concept of it?
So, great question as well. I love that y'all ask questions. I feel like always at medical, it's more like statements and it's not questions. And so here it's actually questions.
Journalism students ask questions.
Yeah, journalism students ask questions. This is great, yes. So I think some of it is framing it as, like I said, we may not have all the FDA-approved treatments, but here are these other things that we have in our toolkit, and maybe we just need to look at how the underlying pinnings of those work. We know you know, when we think about, there is a big study that shows there's like a tryptophan and then serotonin deficiency early in, you know, the pathobiology of people who get long COVID. So in some cases, we know that SSRIs may help with that. We know that sometimes SNRIs might help with POTS or with like pain that patients have. So I'll say, well, let's use what we have in these other disease states and try it with you. And then I think there's, you know, medications we're learning that some are going to be more anti-inflammatory on the body. So then I might say, let's try, you know, we know there's inflammation going on with long COVID, and we know that, like, for example, metformin is something that is one of those medications that when patients took it early on after COVID, it decreased their risk of getting long COVID. And I think that's some of its work on inflammation. And so I will sometimes use it later on just to see, will it help with inflammation, especially if someone has another kind of phenotype, or like they're gaining weight and they're kind of getting a little pre-diabetic, then maybe it's, a nice medication to use. And then there's, as far as treatments, I've found a lot of patients get help with low-dose naltrexone, and so that is something that I've used a lot. And before, we'd use it maybe in neurologic conditions or in chronic pain, and but if you look at how it works, again, it's kind of modulates the immune system and decreases inflammation. And so I think we have to kind of look at these things and educate people that way.
Yeah, I think as a reporter, a couple ways I think about this. One is trying to differentiate between like symptom management strategies and the actual search for approved treatments. I think it's important to acknowledge, like you were just saying, that there are a bunch of things that we know can help with symptoms, especially if people have been diagnosed with things like POTS or ME, where there are kind of established strategies for treating that. But then it is also important to emphasize the search for treatment specific to long COVID and things that could be FDA approved for long COVID, particularly as people are dealing with all the logistical challenges of actually getting different treatments or different drugs. Like, will insurance cover something that's not approved for long COVID, right? I think it can be a challenge. And the other thing I think about in doing this reporting is always talking to people with lived experience as experts, particularly in reporting on Recover. I thought it was important to ask people in the patient advocacy community, are you excited about these things that are being tested in the clinical trials? And many people were saying, no, I've tried all of that. I've tried these things and it didn't help me. And that experience is very, very important to lean on as a journalist. And I think there is more recognition, or there's starting to be some recognition of that experience too. So I wanted to just shout out this program called Cure ID, which is run jointly by the FDA and NIH. And that is basically, they run surveys trying to collect data from people on off-label drug uses. So if you're someone with long COVID and you've tried a bunch of stuff, you can go into this survey platform and basically log, here's what I've tried, here's what's been helpful, here's what hasn't been helpful. And once they have data from enough people, they're going to start analyzing that and try to pull out signals for clinical trials. So I think there are other less formal attempts like that too, to try to understand what are people already trying and what can we learn from that experience, rather than going through the expensive and complicated process of setting up clinical trials for a treatment that people kind of already know is maybe not super helpful.
Hi, my name is Jessica, and I'm a prospective student. So I keep up with COVID updates, and I feel relatively well informed on the illness compared to just my friends and the people that I'm around. But I also feel like I have personally a lot of health anxiety, so that I often will fluctuate between feeling kind of frustrated with the lack of coverage or the lack of information the general public has, and then telling myself, oh, maybe I'm being too dramatic or too sensitive about it, even though I feel like I have that information. And maybe this is just because I haven't started my science journalism career and education yet, but as two people who work in this field, do you ever feel frustrated with, I guess, maybe potentially feeling like the world is moving on when maybe they shouldn't, or feeling maybe abandoned by some people who are supposed to keep people safe? And if you do feel that way, how do you deal with that? Or if you ever come across, if you're ever conversing with someone, or as a reporter, if you pitch a story and it gets rejected by an editor, and if it's invalidating, how do you deal with those feelings in your work?
So the CDC right now, everyone's
yeah.
Really mad. The CDC just came out with new updated guidelines for after having COVID, and it's just oh, if you don't have a fever, just go back to your life, don't wear a mask, da da da. And it's like, okay, you know that.
Wear a
like-
mask for 5 days. That's the guidance.
Was that it?
That's
It's
it,
like,
yeah.
that's
If
it.
if you don't have a fever, wear a mask for 5 days, and then you're good.
Right.
Yeah.
Yeah.
So it's pretty minimal.
Yeah. So memes, dark humor, that's what gets me through. I don't know. Like complaining on X. I don't know.
Yeah, I mean, I dealt with this by starting a new publication to cover long COVID, because I wanted to do the stories and I was having a hard time getting them placed elsewhere. And I will say one thing that has been kind of gratifying is a lot of people have been pitching us. We are working on fundraising so that we can actually pay those people who are pitching us, because so far we've been saying a lot of, our budget is really small, sorry, but we're working on it. So I think the interest in the Sick Times, I think, has shown that there is an appetite for this reporting among people who have long COVID, of course, but also like their friends, their relatives, people in the medical community, people in the research community. And so as frustrated as I often am at the CDC and other institutions, I think it gives me a lot of optimism to see that kind of response.
From a science part of it, actually, like there is so much research still coming out around
Oh, yeah.
COVID and long COVID. If you look at, I'm on an editorial board of one of our PM&R journals, and the most cited research last year was things that had to deal with like effects of COVID. So there's still science, there's still so much that's talked about around it. You know, even the Senate, the Help Committee had, even though they're not passing any laws right now, they are still at least talking about long COVID right now. So we just have to like think long game and think like, okay, we're gonna, and it's important work that you're doing and that you're wanting to cover it and that you want to, continue to fight for this. Whenever I get interviewed by the media, I always have patients that come in, oh, it's because we saw you on TV, or because we saw, or that's my doctor, and they tell me about it, so.
Good question. Next, please.
Hi, I'm Rambo. I'm a journalist. I have questions for both of you. How does misinformation and disinformation figure in your line of work? How do you deal with it in your own personal capacity? What are your strategies? And what do you think are structural changes that need to happen so that they're addressed?
Definitely there's a lot of misinformation around COVID and long COVID. I think it comes in many different forms and from many different directions. So for example, there are the people who are like complete denialists who think that COVID doesn't exist or that long COVID doesn't exist, or the kind of misinformation of it's just a psychological thing, which we know it isn't. There's been plenty of research showing that. Then there's also, there are also other forms of misinformation of, maybe having like ideas about long COVID that have been not borne out by science, like the fact that it might be like a psychiatric condition. And there's also, I think, a lot of not misinformation, but a lot of challenges kind of posed by misinformation, like in the long COVID community too. Because it can be hard to find reliable information on certain topics sometimes. Like if you look up potential treatments, you'll find a lot of snake oil or a lot of things that maybe don't have a ton of evidence behind them. And so obviously people, I think, have every right to try things that they may find helpful. But it can be tough as a reporter to kind of understand like, oh, I'm getting some email from someone who claims to have cured long COVID. Like, that might not be legitimate, and that you might have to really vet that carefully before you do a story about that. And I think there's also a lot of conspiracy theorizing that goes on about things like this CDC guidance, like how did that happen? Does Mandy Cohen believe in eugenics or something? Like, people I think also get pretty extreme out of anger and out of frustration at the kind of abandonment of these institutions. And so I think that is not misinformation exactly, but sort of a similar challenge of like the lack of like legitimate reporting that's going on these topics. So, personally, I would like to see agencies like the CDC do more to really put out good, like correct information about long COVID, because right now it can be hard to cite kind of official statistics and stuff. I don't know if you want to add to that?
To add to that, there was a lot of misinformation. Probably the most was around vaccines when vaccines came out. So that's kind of where I mean, it's still, I can post something on social media and then, people come along and they're like, it's not long COVID, it's the jab, and it's the jab, and just, it was like, there's patients with long COVID who never got the vaccine, and it happened before the vaccine was out, and so, I mean, I can't fight every troll that's, on my site, but, and I have to often let those kinds of things go, but definitely there's still misinformation out there. Just try to get, from a reporter perspective, just try to get, best, well-rounded from voices, all types of voices to see really what is the backstory and what's really happening.
Sarah.
Hi, I'm Sarah, and I'm a student at the Science Journalism program. I'm kind of interested in what you talked about, like in terms of how there's less of a focus on chronic illness rather than like acute illnesses. And I guess I'm wondering, like, how do you think that might tie into just general perspectives or like opinions around disability, and like how we think of disability and whether those things are connected? Yeah.
We live in an ableist society, so definitely that impacts the way the world sees, people with disabilities, and, kind of have always maybe shunned them or put them in a corner, or, wanted to cover, that aspect of it. Not part of long COVID, but I treat a lot of patients with spasticity who have after stroke, which is like when the muscles get really tight, and we inject them with botulinum toxins. And so when I tell patients, like, I'm going to put Botox, they've never heard that it's a medical treatment. They only think it's a cosmetic thing. And so that's just an idea that it was actually around for 30 years for medical purposes before they ever did it for cosmetic. But, no one hears the stories about the medical purposes. They only hear about, the cosmetic reasons for it. And so I think that goes back to, ableism and what we know about people who have chronic disabilities. And I think also in the medical school perspective, they want to teach you, like, okay, this is a disease and this is how you treat it. And because this has been under-researched, under-resourced, so then there's not as many lectures about that.
Yeah, I don't know that I have much to add to that, but I think just trying to be inclusive in reporting is really important to all of this. Like, always talking to people who have long COVID or people who have whatever the condition it is that you're writing about, just from the journalism perspective is really key. Because if you just talk to scientists, obviously they have really helpful information, but that's only kind of one side of the story.
Okay, forgive me, I got here a little late. It was at another event, so if you heard this already, it might be old, but if anybody asks a question relating to the fact that I was reading people who had experienced long COVID at greater incidence for those who were vaccinated than not. That's one issue. The other issue would be, it just came out that the CDC had associated with vaccinations the Guillain-Barré syndrome. You'd think that would have been something they had figured out before they rolled these out, but it's being gone over now. So if you could just address those two issues. Thank you.
So I think at this point in the most of people have been vaccinated. So you're going to see higher number of people with long COVID in populations that were vaccinated. But actually there's better studies that came out that show that vaccination is protective against long COVID. And actually it was like people who got 1 versus 2 versus 3 vaccine series, the more that you got, the less likely you were to have long COVID. But I think still the point is that you can still get long COVID whether you're vaccinated or not. And it does, and so it actually, and vaccines are protective against long COVID. So I think that's where the real data is on that. And then Guillain-Barré has been something with all vaccines. It's not just with these. It's been like known to be a reaction because it's someone's immune system kind of going awry after having something presented to them. But it's really small numbers. I was kind of looking into that. And I thought at the end when I was reading it was like, well, they're not so sure because also COVID can cause Guillain-Barré and nerve problems too. And is it actually more than it would just be in, you know, the U.S. population period, because infections also cause Guillain-Barré.
Dr. Gutierrez, can you just talk quickly about what's going on at the clinics that you've been developing? You know, we're getting, this is something really good that you're doing, the multidisciplinary approach. What have been some of the guiding principles in designing and developing these clinics, and, you know, how are they making an impact?
Right. So first, part of our clinic is, you know, we'll take anyone. We don't even, it doesn't even have to be long COVID. Sometimes patients have been just dealing with chronic infectious illnesses. They've been dealing with POTS, or, you know, and there's not really a place that they feel that they can go. So we're kind of like one-stop shop, holistic approach. We sometimes will do, you know, we have intakes, questionnaires that people can take that look a little bit about like global functioning. We want to look at things like PTSD and anxiety, and not just because we think it's not because, oh, that's causing your long COVID, but it's usually a secondary effect of having it, and we need to make sure that aspect's addressed as well. And we have like questions that we asked about symptoms that they had when they had COVID, and afterwards we want to get, you know, medical records, because a lot of them, by the time they get to a long COVID clinic, they've seen lots of different physicians. The other day, I saw a patient that was like, I came to you for a second opinion. I already went to Mayo. And I was like, oh, I feel like, ooh, I'm like the second opinion from Mayo Clinic. Like, usually it's the other way around, you know, but not this time. And so, and then it's just, you know, listening to the patient. And, you know, everyone, I said, if you've seen one patient with long COVID, you've seen one patient with long COVID, because everyone has a little bit different phenotype with it. And so it's really, you know, listening, validating, trying to uncover anything else that hasn't been diagnosed yet. So is there an underlying, you know, an autoimmune disease that's come out of it? Is there, you know, someone with low iron and ferritin? That's another study that came out just recently showing, you know, iron metabolism issues. Is there mast cell activation that you can find and help control as well? And so it's kind of like then finding these other things that might be the anchors that I talked about, that's, you know, keeping the back, and then just trying to treat symptomatically, putting them in clinical trials. If they, you know, we are a recover site, so I can put them in some of the treatment trials. I'm still waiting for some of those to happen, and some of our like other institutes are trying to do trials and such. So those are, and then the multidisciplinary part is kind of something that has expanded more recently. So it's kind of hand in hand. You know, if there's a patient who's more cardiac symptoms, and I'm going to, or one of my partners will see them along with a cardiologist. Is it someone with a more pulmonary shortness of breath thing, then we'll, you know, bring in the pulmonologist. I have a neurologist that I work really, really closely with, infectious disease specialist, physician extender. We have a neuropsychologist who can kind of do some baseline testing and, you know, see if someone needs a little bit more in-depth testing for cognitive, and then trying to get them resources that we have in the community to help as much as possible.
Betsy, I saw that there's a National Long COVID Awareness Day coming up in the middle of the month. Is that something we should be paying attention to?
Yeah, so advocates last year designated March as Long COVID Awareness Month and March 15th as Long COVID Awareness Day. So this is kind of a grassroots advocacy effort, although there are some groups trying to, like, petitioning Congress to make this official. And my colleague Miles just did a story about some of the different advocacy efforts happening for this month. One is a march in DC planned for March 15th, which we're hoping to cover as well. So definitely, I think there's a lot going on right now. A lot of people also have felt very activated or motivated to do this work with the recent CDC guidance change and other kind of federal policies. A lot of, you know, impetus to push for more research funding and more support for clinicians and other things of that nature. So I think there's just efforts for outreach, and definitely something to look at for other journalists. You know, is there an event happening in your local community, or I think a lot of long COVID advocacy happens online because of the nature of the disease. So looking at some of those different efforts. Also, for the Sick Times, we are excited to have a donation matching opportunity for March, going along with Long COVID Awareness Month. So for folks who donate to us, that will be matched by a foundation called the Silver Giving Foundation. So just a little plug for that for folks who are watching. Yeah.
So just to quickly follow up on that, I was listening to Monica describe her clinic, and it seems like an ideal place to sort of situate a feature on how do you deal with a novel condition. It's not really novel anymore, but relatively novel. So that's a story idea. But I didn't want to end this before pointing out that Betsy is doing something that some people in this room, are particularly interested in, which is, the sort of the entrepreneurial, enterprising, I see a niche, it's not being filled, and so I'm going to try to fill it, even if I have to do it on my own. And, that is super admirable, especially because you're doing something that's so important for public health. But I also think it's probably important to address the practical side of this, like, can it be done? And what is the timeline? And how does one do it? Because I know there are people in the room who have their own passions and see their own unfilled niches and would like to do the same. So any sort of status report on how that's going and lessons learned would be really helpful for this group, I think.
Yeah, definitely. So it's not easy. It's a challenging process, and I think takes some planning to prepare for. Like, I wouldn't be able to do what I'm doing with the Sick Times if I hadn't built up a freelance career over the last couple of years, to a point where I now have like other work coming in. So the Sick Times, we've been fundraising. I mentioned this matching opportunity we have right now. That was our first kind of big grant. Before that, we were really just getting, small dollar donations from readers. And Miles and I have been working essentially as volunteers on this project for the last few months. So definitely I had to kind of prepare my own like financial situation to be able to do that, and I know he has as well. So I think that is sort of a caveat that you have to think about. Also, I had this prior experience with the COVID data newsletter that I was writing for a couple of years. I think that taught me a lot about just running an independent publication. That one was a little bit smaller scale because it was a newsletter just by me. But still, getting yourself into a schedule of publishing once a week, thinking of story ideas, keeping track of different sources, like all of that takes really practice over time. And so I think a lot of the lessons learned there we've been applying to the Sick Times, and trying to really, keep track of our bandwidth, wear a lot of hats, trying to prioritize, thinking about, like, for example, which social media platforms do we want to spend time on, what makes the most sense for us, where are we looking for fundraising, how are we thinking about the top stories to do. There's just 2 of us and there are so many stories, plus, as I mentioned, a lot of freelancers pitching us stories. So trying to kind of figure out what to prioritize is a constant challenge, but I think we've been really glad to see the response from people who are reading it and to hear that the work we're doing has been helpful to people with long COVID, which is really the primary goal, is to be useful to that community. And thinking of ourselves almost like a local news publication for the long COVID community, which is millions of people, deserves a local news publication, I think. Like similar in scale to any large city, right? And so trying to kind of give people actionable information, like studies that they could bring to their doctors, updates about what's going on in different political spheres. I think that's what we're working on, and I think we have a long way to go, but we've done some good stories so far, so I'm proud of where we're at right now.
Yeah, it's a very good publication. I guess we'll end. Dr. Gutierrez, what stories do you think we're missing? If you had to choose 1 or 2 things that you would really like people in this room or journalists to pursue, on long COVID or other post-viral conditions, what would you direct our attention toward?
I know, I think some of the direction is going to be that it's not over, that, this is something that may even get worse with reinfections, that we still don't know what's going to happen down the line with long COVID. I guess my backstory is, the National Academy of Medicine is going to be coming out with a definition soon of long COVID because they were asked by HHS to do that. So that should be a hot story that's coming out. And so, bring a lot of attention to that.
And you'll let people come visit your clinic and report, maybe?
Yes, for sure. Yes, I'm all about I'm friends with our media office that has to get involved at our institute, and with even sometimes local media, and I'm always willing to spread the good news about, or I try not to say the bad news. The good news about what work's being done to help people with long COVID, because I want the education to be out there, because that's at least and I even do it in Spanish, even though it's maybe not as good as in English.
That's wonderful. Well, if you're frustrated about a topic being undercovered, such as long COVID, you're in the right place, you're in the right program, keep doing your journalism, and this is where a lot of us channel our frustration at things being undercovered. You have within your control things that you can do about these topics that are undercovered, so pursue those passions. And I want to thank our passionate and experienced and expert speakers tonight for a wonderful conversation.